It's my pleasure to introduce Dr. Marina Lalayants. When exploring who could be a keynote for this conference, she was an easy pick. Her expertise and work is right smack dab in the middle of interdisciplinary work in child welfare. Dr. Lalayants is an associate professor and chair of child welfare, children, youth, and families field of practice at the Silberman School of Social Work at Hunter College, the City University of New York. Throughout her professional career, her interests have been examining and responding to the needs of low-income families, children, and youth in child welfare. In response to such complex and multifaceted problems as child maltreatment, Dr. Lalayants has extensively studied multidisciplinary collaborative efforts between child protective services and mental health, substance abuse, domestic violence, medical service providers, and law enforcement, while combining the organizational and clinical dimensions to identify best practices associated with successful collaborative practice implementation. Welcome, Dr. Lalayants.
I am so grateful and honored to be here today and participate in this amazing conversation on such an important topic as interdisciplinary collaboration in child welfare, and with such an amazing group of diverse professionals representing various disciplines. Thank you for the wonderful introduction, Stacy. I am a professor at Silberman School of Social Work at Hunter College, which is in New York City, but I'm also a researcher, and my experience with interdisciplinary collaboration ranged from working in agencies that implement interagency collaboration. I worked at a child advocacy center in New York City, to researching multidisciplinary practices and working closely with organizations on evaluating and building evidence on interdisciplinary collaboration within their agencies. Here we go. Many of you have used the terms interagency collaboration, multidisciplinary teamwork, cross systems, partnership, consultation teams. There are all kinds of various terms. What they all describe is really the framework or practices that bring professionals together in order to serve families and children better. Why we would do that? Because as Dr. Lalayants and Dr. Blakey mentioned, child maltreatment is such a complex problem. It's affected by a number of disciplines. There is law enforcement, there is substance abuse, parental substance abuse, mental illness, domestic violence, educational neglect, medical issues. There is a host, housing, disabilities. There is a host of issues. And the literature has shown that, studies have shown that there are links between child maltreatment and all these various needs and challenges. There have been links found between domestic violence leading to maltreatment or co-occurring substance abuse, mental illness, and sometimes they can all co-occur in one case. Being such a complex problem, there is no one profession, there is no one discipline that can really address it all. So we require to bring our heads together in order to figure out what's happening with the family and how we can provide better services for them. And there are a number of studies that talked about benefits. So what happens as a result of interagency collaboration or multidisciplinary teamwork, whichever term you want to use. So there are benefits to families, to children. For example, there's less trauma. They get services quicker, they get referrals, and they get connected with services quicker. There is a more holistic perspective, holistic view of the situation, more accurate assessment of what's really happening within the family, more appropriate interventions. It could be culturally sensitive interventions, more family focused, decreased duplication of services, and fragmentation, and they generally get a larger support system around them. It's important to note that there are also benefits to the workers and the organizations that are involved in this work. So studies have demonstrated that there is a more efficient use of agencies' resources. Again, there's less duplication. There is information exchange in a faster manner. Enhanced practice through collaborative and shared knowledge, perspectives, shared insights. There are mutual learnings, more accountability and less bias. And also studies show that it helps, when you work with others, it helps reduce burnout and it creates mutual support among workers. So what I would like to do is I would like to share an example of interagency collaboration that was implemented in New York City by the New York City Administration for Children's Services, ACS, or we call it ACS. This is the government agency that oversees all child maltreatment cases in New York and oversees the well-being and safety of children of New York City. And they handle about 50,000 cases of child maltreatment a year. Clinical consultation program that they implemented is a collaboration between Child Protective Services and nonprofit organizations that have expertise in domestic violence, substance abuse, and mental health. That was the initial setup of the program. Later, as a result of this study, we identified that there is also a need to bring in medical consultants. So they added a medical consultant nurse practitioner to the team. So I will present some of the implementation processes, the key factors that promoted collaboration, talk about challenges because there were a lot of challenges doing this work, and what are the lessons learned, and how we can all move forward with this knowledge. So the clinical consultation program initially started with the Child Protective Services and the 3 consultants that I mentioned, later adding the medical consultant. They created 12 teams. Each had a team coordinator with them. And they were all co-located with CPS, but they had different structures. Some were in the same building, some were in the same office, and co-location actually mattered in terms of building relationships with the team members. So the goal was to really work with CPS on those complex cases where all these multiple disciplines are involved. And the reason for choosing these specific consultants came out from focus groups that the agency did initially with the workers to see where they're having challenges, what are the cases that they're struggling with, what are the issues that come up most frequently with their cases that they're having actually difficulties. Perhaps it's the substance abuse of parents that they cannot really diagnose, assess properly, and they confuse it with mental health symptoms. So these issues, the choice of consultants came out of focus groups with Child Protective Services workers. So the consultants, the idea was that to bring the consultants work with CPS together as a team to work on complex cases, also provides resources that are specific within those disciplines, because child welfare workers do not know what exists in domestic violence or substance abuse or mental health fields. So when we spoke to the Child Protective Services workers, what the program has done for you in terms of bringing the consultants, what have you obtained from this collaboration? They all shared the first thing, that it opened our eyes. We learned so much. It gave us insights into our cases that we didn't know before. It helped us see a larger picture. It gave us the discipline-specific knowledge. Our interviewing skills when we talk to parents, and consultants actually modeled interviewing with the parent for caseworkers. They shared resources, and it helped them reduce bias. And I have there's no better way to describe this than just give some of the quotes that came directly from the workers. So this one person said, talking to a consultant, I was able to understand the victim's perspective. Consultants helped me realize that the way I used to approach a DV victim was to penalize her for her partner's actions and forcing her to do something, or else the child might be removed. I now feel I'm being more helpful and less judgmental. They also talked about looking at the case as a whole and discussing it thoroughly, understanding what's happening, what are the multiple issues affecting the case, trying to prioritize if there is just so much going on, coming to a consensus, what has to take place now and what can wait. For example, it allows us to see how the multiple issues may be interconnected. If we just concentrate on one area, we may miss out on really helping the clients because of a multitude of issues. We need to see how they interlock with each other. It also helped workers verify their decisions, since child protective workers are the ultimate decision makers in the case, especially in this initial stage of being involved, the child being at a risk of a removal. They are the main decision makers, and often they felt unsure. Am I making the right decision? Because they are the only one making the decision. So having the consultants involved in these cases gave them the confidence that they're doing the right thing. This is the right decision. They also talked about witnessing improvements in terms of client outcomes. As a result of having the consultants with the specialized knowledge and working with them, the workers shared that we see the families actually understanding why we have all these services around them. Sometimes families might be resistant. I don't need, parenting classes. I don't need mental health. So the consultants with their specialized knowledge were able to talk to the parents in a way that they would be receptive, and they would explain them things that they would accept. So for example, I see an improvement when I can get a family that's been through the system many times to finally accept services because it was their consultants' work that made them come in for services this time around. I've had a family that's been with ACS for the past 10 years. They'll say, what can you do for me? I've been to court. They can't make me do anything I don't want to. Then I get the consultant involved and they explain the benefits of services in a way that parents are receptive. So the workers shared that connecting parents to services and witnessing family progress was one of the among those outcomes. Workers also shared that having consultants created a different environment within CPS offices because they brought in their culture into the child welfare organization. They felt that they created a safe environment to talk to someone, to vent, and address some of the issues. As one of the workers said, it's different from talking to your supervisor, because when you're talking to your supervisor, sometimes it feels punitive. The supervisors or the managers would be asking, have you done this? Have you done that? Did you see the family? Did you ask this question? But with the consultants, it's a more supportive approach. And they felt that the consultants were available, accessible, and they commented on some of their interpersonal skills of being able to communicate with the workers. The consultants make you feel welcome. They're very easy to talk to. I use them as much informally and as formally. The consultants also organize sometimes lunch hours for the workers, where they would have sessions with them about secondary traumatic stress or how to prevent burnout. So they would address such issues that workers are dealing with, but the supervisors on regular basis are not really able to have the time to address such issues. Then we explored what are really the key ingredients that promote interagency collaboration. What is it that makes it work? So among those fundamental elements, and they can be pretty much transferable to any setting, to any type of structure of interagency collaboration you're interested in setting up. First is really setting shared goals. What are our common goals? We're all working towards the same goals. So let's outline them. Let's understand what our shared goals are. That evolves into the development of an understanding of becoming interdependent. I can do my task, I can achieve my goals because I rely on you, because I depend on you. So there is this interdependence. And one of the examples, in a cross-consultation means that where there are multiple disciplines involved in a consultation. So in a cross-consultation, the case is always affected by multiple disciplines. So we all depend on each other. We talk and provide information to each other. There are so many different issues going on with the family that we always have to consult with each other to be able to respond to client needs. Then it's flexibility, openness, and understanding that all disciplines are equally important. So this is related to interdependence, but it goes beyond that and refers to deliberate occurrence of role blurring. And these examples will explain it. We met for a cross consultation and we were asking questions across each other's disciplines without being so rigid in ours, which is really important. We look at cases on a case-by-case basis and we try to be flexible. When there are multiple issues involved, we cannot be insisting on our formula that's not going to make sense for the family and will make any kind of service plan impossible. It is willingness to know that there are other perspectives and other lenses, and it's okay to disagree. Then they all talked about the importance of interpersonal communication skills, how people approach each other. It's really basic when you think about it. It's really building relationships with one another, being respectful, tactful, supportive, having an ability to listen without interrupting each other, without criticism, taking turns when talking. These are all, when you think about it, it's common sense, but these are important ingredients. Finally, I cannot state the importance of having an effective team leader, having a strong team leader who understands what the team is doing and guiding the team. The role of the team leader is multidimensional. They help set up relationships, communication channels. They get involved when there are issues, when there are challenges. They troubleshoot, they coach, they do everything. And they help work issues out within the consultants as well as with CPS. And I love this example that one of the team coordinators gave. I always use this analogy of the orchestra. We got drums there, we got wind instruments, and they all can play separately. But then when they come together, they have to be able to harmonize. And if they can't do it, they're just going to make a lot of noise. And it's my job as a team coordinator to orchestrate them, to come in, step out, move up. Then, like I mentioned earlier, it's super important to talk about challenges because there are many challenges, especially in the initial stages of implementation or thinking through setting a teamwork or partnership with other disciplines. It's important to anticipate those challenges, to understand them, and to figure out ways how to address them and improve services. Number one barrier that we had with the program when it first started, barriers in utilization of consultants. We had consultants in the offices, no one is coming to them, no one is talking. And that was going on for some time. The reason, because of lack of understanding why we need the consultants, resistance from the workers saying, well, I've been doing this my whole life. I've been here for 30 years within this agency. I know how to do things. I don't need consultants coming to me and telling me how to do my job. That was a big challenge. The consultants had to And we didn't have a roadmap. We thought we're bringing these consultants into the offices, it's going to work so well. No one comes to them, or they challenge their recommendations. So consultants had to be creative. They organized breakfast, brought in donuts, yes, that works. It's all building interpersonal relationships. It's all about building relationships. They started doing it informally. They would just walk over to the consultants, to the workers, introduce themselves. How can I help you? Just to show genuine support, that I'm not here to scrutinize your work. I'm here just to support you. Use me. So it's getting them, CPS workers, to understand why all three disciplines are needed. First, they were like, oh, too many people. Why do I need you? You're a consultant. Why are you different than the other consultant? Oh, two different disciplines. It's like, why do you need an electrician and a plumber? Aren't you both laborers? A lot of people were thinking, we've been doing this without the team, so why do we need them all of a sudden? So in the beginning, I put them to the test. I didn't want them to waste my time. Then I saw they knew what they were talking about. They were very helpful. So a lot of it was actually word of mouth. One person goes, engages the consultant, and they see how helpful it is to work with them on a difficult case. Then they tell others, you know, I actually talked to that person and she told me this and this. You could try it. And that just started to roll. But initially, the program was underutilized, and then it became overutilized. That there was a waiting list to use consultants. So that was another issue. Another barrier was cultural differences. We have CPS, it's a government agency, very legal environment. And then we have nonprofits who have a different approach. So differences in professional approaches and organizational cultures is something we should anticipate when we plan to engage into interdisciplinary collaboration. As one of the consultants said, ACS sees things quite differently than we do. ACS comes from a much more punitive perspective. We're investigators, we have to find out who is wrong. And consultants are social workers. So social work doesn't necessarily, we're coming from two different sides. There are cases where clinically we might want to put things in place and it might be a long process, but because ACS comes from a legal model and there is a time limit where they have to move the family throughout the process, so a long-term interventions might not work. So they had to change their approach and think more crisis intervention driven rather than more long-term in that particular case. Another pretty significant challenge was that there was a lack of formal collaborative protocols or a manual. We didn't know what are the rules for this? What is the structure? We learned as we went. So it's important to set the structure, to have the protocols for joint activities, who engages who, in what cases, what happens, to have it written, because again, based on organizational cultures, people operate differently. So for example, CPS workers are used to directives. They have to be told these are the things that we need to do. We have to move things along. Whereas nonprofit organizations, they don't operate within those timelines. So often CPS workers wait for directives from the top. That's their culture. So formal protocols outlining collaborative practices and meetings would be helpful. And it would also create more dialogue between people, that you know you have a protocol, you have a manual, this is how we work together. It helps people to know who is doing what, when, and how. So if we summarize the critical factors, it all boils down to three key components: commitment, communication, and strong leadership. So and they're all interrelated. They all depend on each other. Commitment means pre-planning. For example, those challenges that I just mentioned, we have some knowledge already about, so we can plan forward. understanding the various cultures, understanding who you are engaging with, what their cultures are, how they operate, and how that affects your work. Conveying common goals, setting common goals, and having workers buy-in early on, having everyone who is going to collaborate, having their buy-in early on, so that it's not just dropped on them, we're doing this tomorrow. The leadership knew, but the actual workers didn't know. Providing resources and supports. Communication means establishing protocols, manuals, channels for communication, for feedback. And strong leadership is on multiple levels, supporting, supervising, and troubleshooting. So in summary, interdisciplinary collaboration is a process. It's a developmental process that takes time, efforts, energy, pre-planning. It's interactional, strategic and deliberate actions are needed. Supports, formal, informal, are needed to sustain the practice, to develop and sustain the practice. Also very important to build evidence, have some kind of feedback channels so that we know what is working, what is not working. Like I mentioned, when we did the study, it was in the earlier stages of implementation. We were learning about what we were doing. We were learning what was working, what was not working. We learned that we actually need a medical consultant on the team. We learned that we need protocols. We need supervisors' involvement, because originally it was designed in a way that it was targeting involvement of workers, but we realized if supervisors are not involved in this work, then they cannot coach their workers. They cannot fully understand what's the program offering, and they cannot convey those goals and convey the information to their workers. So it's important to include the management into this, the middle management. And just building on successes, knowing where we're making a difference, where we are effective, where we're not, what's working, what's not working, and how to build on that, how to celebrate, how to reward collaboration. What are some of the mechanisms that would promote that? Finally, the last point, and I want to leave you with this thought. When we think of working together and bringing all these various disciplines together, it's wonderful. We should be doing that. But we also need to think how we bring the family into this process. Because without the family, none of this is possible. None of this is going to be successful. We need to think of how we bring the family into the collaborative process and make sure that they are participating in this process, make sure that they are at the table when key decisions are being made about the family and their voice is being heard. Only then, interagency collaboration, multidisciplinary work, any case planning, only then it will be successful and it would lead to positive outcomes. Thank you. I have some references here of studies that we published, papers that we published from the study. In case you're interested, let me know. I can send you all of them. Thank you.
Thank you. Thank you, Marina. We have a few minutes for Q&A. And so if you have a question for Marina, raise your hand and Kate in the yellow is gonna come give you a mic. And if there's any online questions, go ahead. And Ariana is gonna help out. So any questions for Dr. Lalayants?
Thank you. Can you hear me? Okay. So I'm really interested in the research because I've worked and facilitated multidisciplinary child protection teams in the past, and actually have started some in different counties over my career. As you did, and one thing that I always note is the differences among states and how what their child protection system looks like. And in looking at the study and the comments from the workers who were involved in the study, it sounded at the time of the study that the ACS approach really was more of a criminal approach, the investigations, the finding guilt, et cetera, where here in Minnesota, I think we have a much more strengths-based, family-focused approach looking at how we build on the capacity of parents. So what changes have you seen in the ACS approach as a result of the collaborative multidisciplinary approach and as well in terms of outcomes for families?
Thank you for the question. You're right on. There has been a lot of change. First of all, this model, the multidisciplinary model in general, came out of the need in response to a fatality of a child where there was no integration among services and disciplines, and the case fell through and there was a child fatality. So it came out so that was already a policy and a change in place. And then the culture of child protection has in the past had more aligned with law enforcement rather than social work. And I think one of the main reasons is that child protective services workers in New York City are not social workers necessarily. Ideally, they would be, but they don't have social work degrees. So they go through academy training for 6 months, but they can have any degree, bachelor degree pretty much. Not necessarily, we didn't even have BSW programs in New York at the time. So there has been, but from that time, there has been a lot of change that has been happening. There has been more trauma-focused approach implemented in training and just trying to infuse trauma-focused, culturally sensitive. And this program was set to do that. With the help of the consultants, bring in trauma-focused knowledge, culturally sensitive approaches to families and family-focused. I want to say that there has been a lot of changes and improvements within the child welfare system in New York City. And this is not the only intervention that is targeting changing the mentality of the organization. If you're familiar with New York ACS, it's a huge bureaucracy. Changing things, it's not easy as it might be in other states or counties. But there has been a lot that is taking place, bringing in evidence-based models. There are lots of interventions that are working towards changing the mentality. And me being involved with many of those and doing research, I have witnessed how much the child welfare field has evolved in New York City, how much it has become family-oriented. My latest research has focused on bringing parent advocates and parent representatives into these meetings so that the parents have someone who is on their side, right? Because often they are intimidated to participate. Even if they're at the table, they are intimidated by all the professionals. So the New York City has implemented an initiative that every parent will have a parent advocate at the table during these various meetings representing their voice and their interests. So I'm very hopeful.
Hello?
See, it's just me. If we were to implement collaboration with Fidelity that you were describing, how long do you think it would actually take to set up with the protocol, the buy-in, all of the steps that you discussed?
So that's a good question because it depends who is on your team, organizer's team. Usually it starts, well, like I mentioned, it started with really doing focus groups with the workers to see what they need, who they want to collaborate with, what disciplines. So it takes some groundwork, kind of needs assessment of the agency to see what are the collaborating parties you want to begin with. And the group can get bigger with time, as you realize, like in our case, that we need medical consultants, and they actually mentioned we need an educational expert, because we are dealing with the Board of Education, with schools, that is like a whole separate animal that we don't know anything about. So we need someone to work with on those cases. Educational neglect, it's a lot of it. So it's identifying who are your immediate partners and working with the leadership on setting up. If you ask me how long it will take, I say it will take 1 year to set up the whole process. Speaking from a very recent experience of setting up a program, I worked with ACS. First, it's a pilot. You would do a pilot on a smaller scale and see how that works. Let's say involve a smaller group of key stakeholders and work with them and implement it for a year, and definitely do an evaluation of what's working, what's not working, what are the challenges, how we can improve this. And based on that knowledge, then you can expand to other communities or offices. So one of the recent examples, I worked with ACS on implementing the inclusion of parent advocates into conferences and into the child welfare processes. It took a good year to bring everyone on board. We had weekly meetings every Thursday for 2 hours. We had weekly meetings with the implementation team, and we had an advisory group with representatives from all the various key stakeholders. You want everyone to be on board. You want everyone to be involved in the design so that they convey that information to their agencies and they're all on board. And it's important that to bring the voices of various potential consultants, not just the management, because they are the ones who will be doing the work, the workers or whoever you're engaging, not just the leadership, but also have some representatives, because they will know what their challenges will be. On an organizational level, it might be in theory great undertaking, but the ones who will be actually doing the work, engaging and working on daily basis with others, you need their voices on the team. But it's a process. It's definitely a process. And it has setbacks, which you come across, various challenges. Well, you can't do this with this agency. So what do? We change some of the policies they have, perhaps, or we work around them.
I think we have a question online.
Yeah, we've got just one. They're wondering who is responsible for the cost or paying for the parent advocates that are a part of the program.
The city agency, the government. They contract nonprofits. So parent advocates are not employees of the city. The city gives funding. They provide funds to nonprofits who train, prepare the parent advocate workforce. So they work for nonprofits, but within the child protection offices. And it was an important factor not to have them employed by CPS, because they wanted to keep it separate. They didn't want parent advocates to be associated with child welfare. And parent advocates are parents with lived experience. They went through the child welfare system and they know ins and outs of it.
We have another question back here.
Hi. You spoke about how the consultant teams were working to, educate child welfare professionals, make parents more comfortable and informed in accessing services. How did the consultants work with youth involved in the case? How were fosters talked with and incorporated in this interdisciplinary process?
So in New York, youth can be involved depending on the age. They can participate independently. If it's a smaller child, obviously it has to be a representative of the child, depending on the situation. But it's either parents or youth. Youth usually have their advocates. Youth I think they're called youth advocates, youth supporters, or certain guardians who would be the middle point. Originally, the way the program was set up, the consultants were not supposed to actually do any work with the families. They were brought in to collaborate with the CPS workers to help them with their cases, but they were not supposed to be involved with families. But that was another change that happened as a result of this learning process, that actually it helps to, in some cases, they didn't want to overwhelm the parents, but in some cases, they worked with the parents directly. So the program is expanded, still having the focus of being it on workers and helping them with their cases. But in some cases, they allowed consultants to be involved with parents and youth directly.
Any other questions?
Can you hear me? Good.
But I have to admit, I still see it's very comfortable for professionals to talk to professionals and to leave the family out of those conversations. So just wondering if you have any good advice or experiences.
Yes, I worked on implementing a family group decision-making model in New York City. And we had a federal grant for 3 years, but we extended to 4 to implement family group decision-making in one of the boroughs in the Bronx. But our model engaged parent advocates because we found that, especially with, and it looks like in Minnesota too, but we thought that especially with our families in New York City, family group decision-making is based on a notion that they have extended family. In New York City, they don't really have that much extended family. So why not bring support such as parent advocates into this and enhance the family group decision-making in order to promote family engagement? Because it is an issue. It's easier for CPS workers just to talk to the consultants or to talk to other professionals. Also, having the independent facilitator at those conferences, who is not a CPS worker or any other professional, helps to keep it neutral. But definitely having the parent advocate at the table, it promotes parent engagement. Having the private family time, caucusing, where they don't have family with them, the parent advocate is there to participate in the private family time and tell them, look, this is your time to think through what is happening during the conference. What is it that they are proposing? Is this doable to you? Do you really agree with this plan? What is your plan for the family? So they try to engage them into this conversation and make sure that they are fully aware what paperwork they're signing at the end of that conference.
Tracy Laliber, do you have a question?
So appreciate all of this. You know, as I'm listening to people and even some of the questions, it's occurring to me that there are these areas of discrete collaboration, conferences or, you know, intake reviews. And then there's a broader collaboration and consultation, which it sounds like this program has some elements of both. I just wanted to share as we were listening, I used to do child protection in Connecticut a lifetime ago. And we had they don't have it anymore, but a very similar process to what Marina is talking about, where there was an educational consultant, a substance abuse consultant, and a mental health practitioner. And they were employed by the state. They sat in the office. Each office had their own team. And then when workers had case questions or whatever, they were just their resource. They were called the resource team. And if you needed them to go out in the field, right, they didn't always go out, but sometimes they would. I have a case, gosh, they've been involved for 6 years. We can't really quite figure out, will you come with me? And they as a consultant could see things and ask questions in a way that as workers we just weren't seeing, we weren't doing. And so to me, that kind of collaboration is more of a blanket collaboration, a partnership. It's very integrated. And that's one way for us to think about that, right? That takes a lot of structure, that takes funding, that takes the will of leadership. And we've got these other opportunities for, especially in Minnesota being a little bit different, these really discrete activity-based collaborations or decision-based collaborations. And I think the challenge for all of us in hearing about your study, Marina, is to really think, I don't know that it has to be either or, but what are the opportunities? And outside of the formal structures, what can we individually do to create those mini resource teams for ourselves? And what that might look like. So I just think those were really interesting.
It's an excellent point, because in some cases people are doing it informally. They have their contact at another agency where they call a person who they've known from maybe a previous job. It's this field is small, so you get to develop your relationships and contacts at other agencies, and you tend to call that person. Do you have any resources you could suggest for me in mental health? I'm working on such and such. So some of it is happening informally, but how can we support this and actually make it more strategic and deliberate and make it more formal and on an organizational level? I think this is the direction that agencies can think of. What are the agencies that you go to on a regular basis? So why not take it to the next level? There's a question.
Any other question? Okay, we've got Kelly.
So in Minnesota, once the families are court involved, it's a very litigious and kind of adversarial system. So I'm wondering where in your process there is, you haven't mentioned attorneys being on your multidisciplinary teams, but I'm wondering about how that fits into your process.
So this work is done in the early stages, most of it. In the early stages, before the case goes to court, during the investigative assessment of the case, diagnosing and seeing what's happening. So attorneys are not involved necessarily in this work, but CPS obviously collaborates with attorneys in other ways. What the team does later, in the later stage of child welfare involvement, is reviewing the case and seeing if services are not working well. Is there anything we can change, or the family situation changes? Is there anything we can do differently to support them? So attorneys are not part of this stage, but I know that they are involved in other multidisciplinary teams with social workers, and there are different setups for that where they have more frequent communication.
Any other questions? If we have one, we probably have time for one more. Okay, over there.
I'm just curious if you have any research on application of this in rural communities where you're looking at really resource limited systems and groups.
So when I first started looking at interagency collaboration, I was in Nebraska, Omaha at the time. I don't call it rural. I mean, in comparison to New York, maybe, but it's not rural. It's a large city. And I did a study of their interagency collaboration efforts. They had a child advocacy center and how they work with multiple disciplines. If you're interested, I have a paper on that. I can definitely share. But to be honest, the fundamental elements, they are the same everywhere. I've done work in the UK where they, social workers, CPS workers partnered with law enforcement and psychologists. I've done work in Russia where they worked with various professionals, substance abuse, child psychologists, and social workers and medical and I witnessed that the elements that make up this work are transferable. They are pretty much similar in every setting. Yes, it depends on the goals of the team, what stage of child welfare involvement they're working on the case, but really the factors that promote teamwork and collaboration, they are transferable to various locations. But I'm happy to share the paper about Nebraska.
Thank you so much, Dr. Lalayants, for coming.
Thank you.
We are so
Thank
glad
you
you did this.
for having me.